Hello everyone, I'd like to welcome to this session on epilepsy. I'm Dr. Elisa Bogossian, I'm from here, Brussels, Belgium, and this is my co-chair, Professor Marek Mirsky from the US.
Hello, good to see you.
And we have a very interesting session with lots of very experts in the topic, and let's start. So I'd like to invite Professor Michael van Putten from the Netherlands, from the University of Twente, to start us with AI-guided EEG interpretation. Thank you.
Thank you very much for the kind introduction. This is my disclosure. So the brain is definitely at risk in several circumstances in the ICU, and we have available many tools to assess deterioration of brain function, and I will shortly touch upon some techniques that are currently in use and that can assist you. And before I go to talk about a couple of things about AI, we shouldn't forget the oldies. There are many situations where there is unilateral damage in the brain. It's not always global, and we have several readouts, in particular the EEG, that is an excellent tool to look at asymmetries, because electrically spoken, the hemispheres generate almost similar power spectra. And the two spectra shown on the right show in blue and in red the average spectral characteristics of each hemisphere. And normally they are on top of one another, and the area in between is close to zero, which is definitely not the case in these two examples. So electrically hemispheric asymmetries are very useful to detect deteriorations in brain function, for instance, as caused by ischemia or by seizures or trauma, of course. And this is an example of a patient who had focal seizures, and actually you can use this index, the brain symmetry index, very easily to detect focal seizures. You don't need any fancy AI or useful AI for that, and in several circumstances just measuring asymmetry works very well. And what you can see here, this is the seizure, this is the end of the seizure, diffuse slowing, and that is well captured by the curves in the right upper panel showing an increase in the asymmetry. And if you would record this for a longer time, this is actually what is happening in this patient. So we have cyclic seizures for more than 1 hour. This is not transient ischemic attacks. That is extremely unlikely, or periodic low blood pressure. So this is a readout for focal seizure activity. It's very simple. It doesn't need a complicated explanation, and it's quite sensitive. So for focal seizures, this is a metric that can actually be used in the ICU, real time at the bedside. Now, this AI, a lot of you may know it, but AI is often divided into machine learning and deep learning. And with machine learning, we still have human beings that define particular characteristics of something that subsequently should be classified, for instance, an EEG, while the machine is used to generate the classification of the patterns. So say we have these two EEG patterns, and on the top panel we have a continuous EEG, normal voltage, and the lower panel is a suppressed EEG. Then one of the features would be the amplitude or the power of the signal. And a human being can make this decision tree. If the amplitude is larger than 20 microvolts, then it is a normal amplitude. If it is less, then it could be attenuated or even suppressed. Now, if you have more features and the decision tree that you want to build becomes a little bit more complicated, then you could use AI, for instance, random forest classifiers or other classifiers to build your tree. And this is work from a couple of years ago, where we were interested in classifying common EEG patterns in the ICU, as observed in patients after TBI or cardiac arrest or metabolic distress. So this is part of the decision tree, and we used a lot of features like amplitude, synchronization, periodicity, etc., continuity, and we asked the machine to build the best decision tree. And that works actually pretty well. This is an example of an EEG showing generalized periodic discharges, and on the right there's the classification into the most common categories in the color scale. Red means increased activity, green is normal, not very often observed in the ICU, and blue is suppressed, and this is the output. So it automatically generates text for you So if you want to discuss it with, say, the clinical neurophysiologist, you can say, well, I observe a symmetric EEG with GPATs, and I would like your advice on what to do next, for instance, unless you are super experienced in reading yourself. Then you may bypass that person, maybe. And this is another example. So once more, human-defined features, but the machine made the classifier, and here the system will tell you this is a diffuse, slow EEG. So very handy for the filtering. Another example where AI comes in is the EEG interpretation of patients after cardiac arrest. And as most of you know, that the EEG has proven to be extremely useful, in particular in the first 24 to 36 hours, to assist in the prognostication. And we've learned several patterns that can assist you in that. If the EEG returns to normal rhythms within 12 hours, continuous normal amplitudes, the neurological outcome is invariably very good. If this is not the case and the EEG remains suppressed, or we have patterns like this, burst suppression with identical burst, neurological outcome is very poor, nicely reviewed in a paper by Bronder a couple of years ago, published in Resuscitation Plus. But you still need human beings to observe and interpret these EEG findings. And here, deep learning can play an important role. So in that case, the machine extracts the features and the machine generates the classifier. And this is an example where we would like to classify pictures between cats and dogs. If you feed such a net with a lot of pictures from cats and dogs, it will eventually learn particular features of the cats and dogs that are not always obvious actually to appreciate, because in that sense it's a black box. But if it is trained sufficiently well, then it will classify this picture as a cat, which is probably what you will do right at the moment as well. Your brains immediately recognize this as a cat, and for most of you, I think this is the first time you see this particular picture. It's not completely trivial, but this is exactly what happens. And we can actually do the same with EEG patterns. So, and then the label does not need to be what the neurophysiologist would describe the EEG as, but in this case we label the EEG patterns with a particular neurological outcome. And in this case, an outcome, the left panel is associated with a good neurological outcome, the middle panel with a poor, and the right lower panel also with a poor outcome, GPATs. And you can train a net with that. And several groups have done that, including our group. So you can train deep neural networks with raw data, EEG patterns like this. And this is recent work where we trained a deep neural network with over 500 continuous EEG recordings. And we used a convolutional neural network with hyperparameter optimization. And we optimized it both for the area under the curve and that the calibration would be sufficient, including 5-fold internal validation. And at present we are working on the validation with an independent data set for testing. But the first results look quite promising. The ROC is almost too good to be true, but we really took care of not over-optimizing and not over-fitting. But of course, eventually we need external data. But this is an example. So these are 3 EEG epochs from a patient after cardiac arrest. And we can ask the DeepNet how to classify these epochs obtained 13, 19, and 23 hours after arrest. And this is the output of the algorithm. So in green, it indicates that the patient has a good neurological outcome. In red, a poor. And the white zone is in between. So most of the time, this patient resides in the red region, indicating a poor neurological outcome. And this is another example where you can observe a nice gradual improvement in recovery of brain function, and also displayed in the curve here. So it starts in the gray zone, but after a couple of hours, around 12, 13, 14 hours, it ends up in the green zone. And neurological outcome is excellent in this patient. And of course, we may also have patients in the gray zone, where I think both for the experts, but also for the AI algorithm, it's not completely clear what the outcome would be of this patient at this stage. So if we compare this with humans can interpret EEGs pretty good. And these are sensitivities and specificities, or sensitivities and specificities both for good and poor outcome in patients after cardiac arrest. And And we can identify approximately 40 to 50% reliably with continuous EEG and human assessment. If we use deep nets, the numbers are way better. So sensitivities for poor outcome are above 60%, and for good, almost close to 90%. So if you record your patient very early with an EEG, you can identify more than 85, 90% probably of patients with a good outcome using the EEG. Of course, we are currently now working on an extended external calibration. I just talked to Nicolas, so we will also use over 500 EEGs probably from Brussels for external validation. And then we will know even better how this works. So can we integrate this in one dashboard in the ICU to assist in the interpretation of the EEG? So say you have a patient in the ICU and this is the recording and you're just new in the ICU. You maybe had one course on EEG reading, but you're still not so very familiar with it, and the neurologist is very busy, and this is the EEG panel, the EEG that you observe, and you're wondering, could this be seizure activity or is it something else? You're not so familiar with the nomenclature at the moment. You still have to read ACNS papers about it. And but then you can ask AI, and there's another algorithm in here, and that will tell you, well, these probably are spikes. At least they have a spiky appearance. And so maybe then this should be treated with anti-epileptic drugs, but you're not completely sure actually. Maybe there's more in this pattern. So you open another panel, and that panel tell you, oh, this is burst suppression. Okay, so this is burst suppression, and with probably sort of epileptiform bursts. And then you call the neurologist and he says, well, is it really symmetrical or not? Well, you can ask the brain symmetry index and say, well, it's quite symmetrical. Okay, so we have symmetric burst patterns with epileptiform characteristics. And then the neurologist comes in and he says, well, maybe we should ask our deep net as well to assist us in prognostication, whether this is really useful or not. And then another panel opens, and which displays you the likelihood that this patient will recover, which is relatively low. So this is all information at the bedside. And in fact, the left panel is maybe is more meant for the neurologist, the neurophysiologist, or the intensivist very well trained in reviewing EEG. But the right panel is for the intensivist, also for the neurologist, but also for the intensivist, I think, or the nurse at the bedside that can serve as initial filtering. And in the end, I think you need two brains, one from the intensivist and one from the neurologist for the final interpretation. So I think AI can really assist EEG, the use of EEG in the ICU. And that is complemented with human intelligence from intensivist's brain and neurologist's brain for final interpretation. So thank you very much, and this is part of the people who worked on this topic.
Thank you, Michel. Do you want to do questions now? Or?
Sure.
Okay. Any questions from the audience? Because I think it's easier to just ask the speaker immediately after if there's anything that you'd like to do.
If you have any questions, just press the red button that has on top someone speaking.
Michel, what epoch of time do you record for AI? Because the neurologist will be using typically continuous EEG or prolonged interval in EEG. What is the same epochs you're using for your study?
So we do continuous EEG.
Okay.
And we hook up the patients ideally within 6 hours, actually as soon as they arrive in the ICU. So during daytimes, it's typically on within 2 hours. And when it's at the night, we do it in the morning. But it's continuous, up to 3, 4, 5, sometimes a week, days a week.
Yes, Jan.
In your AI model, sort of what the data input, do you only use EEG? Because in the ICU, obviously, we have access to a lot of data other than EEG. And for example, if you think about predicting outcome, that could, of course, also aid, like, for example, the heart, the EKG, and things like that.
Yeah, so a natural extension would be to combine, indeed, EEG with wet biomarkers, NFL, NSE, hemodynamics, etc. But that still is not so trivial to do, and so this is where we decided to start. Yeah, but of course that's next step. Yeah.
Yes, over there.
Thanks for the presentation. I'm Tomás Fariña from Madrid. Do you have tested or thought to test the data with a simplified EEG? Because in some ICUs, in my city, we don't have 24 hours a complete EEG. We perhaps have a VIS or another simplified way to take the raw data. So do you have thought of that? I mean,
Yes.
Or try it?
Well, if you can't measure continuously, of course, you can do it intermittently with spot EEGs. And you can also use a reduced montage, say 4 channels or 6. That is possible. If you want to use AI, you would have to retrain the net on those data. But that's not rocket science, because if you have trained it on 21 channels, it's relatively easy to train it on a smaller number just by removing them. But indeed, it's also something that definitely can be done. Yeah.
Are you able to detect drug effects or other complications that may influence the reading of an EEG that a clinician would certainly have available and say, oh, this might be reflective of that?
Maybe. So for the cardiac arrest patients, I mean, they're either under, most of them are propofol, some midazolam, some cefaflurane, and that doesn't seem to affect the interpretation of the EEG significantly. But if you would label them with the anesthetic, probably the deep net would be able to find out what the anesthetic is. But for the ultimate prognostication, it is probably not relevant in these patient categories.
It's a super interesting question, right? Because it's been clearly shown that in the EEG there are very distinct, specific signatures depending on what anesthetic is used, right? So, I mean, for example, dexmedetomidine has a completely different signature to propofol or benzodiazepines, and I think it could be interesting to think that using these sedatives in the disease context probably alters the signature and might have very specific alterations because it's then 2 variables, right, at least.
Right. I know from one study where they looked at cardiac arrest patients, but not AI-assisted visual analysis with cefaflurane. And actually, based on the standard patterns that we use now for outcome prediction, that worked a little bit better with cefaflurane, because the likelihood of inducing suppression is a little bit less in the good brains. So their sensitivity for good outcome prediction was better, actually. So in that sense, it is definitely relevant. I do agree. And whether you really need it for a reliable outcome prediction, I think it's not so critical. Yeah, but maybe it's better to use cefaflurane because it increases your fraction of patient with a good outcome using visual analysis. But it's a little bit more complicated, of course, in the ICU to use that.
Well, thank you, Michel.
Yeah, okay.
And for our next speaker, we have from the United States at Columbia University, New York, Claassen, who's going to tell us about what seizures maybe we shouldn't treat in the ICU.
Right, so I hope to connect directly to Michel's talk where he talked about how to diagnose these and how to sort of, detect these with really advanced technology that hopefully will be coming to our bedside soon. So my disclosures, I'm going to try to focus primarily on treatment, right? So seizures, how common are they in critical care, predictors of seizures, what non-seizure patterns that are relevant for seizures, for the management of seizures. We will briefly touch on status epilepticus because I think Cherylee Chang is going to focus on that, so trying to not have too much replication there. Focus on talk about seizure prophylaxis and the management. So this is what we talk about if we just want to think about a classic seizure, right? This is relatively easy to detect visually, right? You can see the rhythmicity that builds up, stretches for at least 10 seconds. It's a very high frequency pattern. That's what we're going to talk about when we talk about seizures in the ICU. So how often are these? I think there's most of the data on status, but there is this really great paper by some Snyder that used a huge data set of 12,000, more than 12,000 critically ill patients monitored by EEG, and found that in that cohort, 10% had seizures, right? So that's an idea about the epidemiology of this, but of note, those were patients that did get monitoring, right? So there was a bias of selecting patients. Somebody thought about getting an EEG in that context with different brain injuries. About 10% had seizures. There's an annual incidence of status of 20 to 40 per 100,000. It's J-shaped sort of curve. That means it's more common in the very young patients and a lot more common in the older population. A lot of them have actually epilepsy at prior, but not all, about only half of them. It's not limited to ICUs that focus on patients with brain injuries. That has been shown in pure medical and surgical ICUs that excluding patients with brain injury. So all of us have to know about that. It's not just for the neurologist or neurointensivists. So when you look at this here, the table on the left, you can see there that depending on what kind of admission diagnosis you have a different rates of electrographic seizures. It's most common in patients that had convulsive status earlier and then stopped seizing. In patients with inflammatory or infectious diseases, it's particularly common. You can see there infectious encephalitis, autoimmune encephalitis. It has the highest rates of electrographic seizures, but also in other patients with trauma, strokes, you can actually see this in quite regular frequency. Most of these seizures, when you encounter them in the ICU, don't have convulsions. So in your mind, don't have that picture of a patient that is shaking all over the place in the bed. They may just lie there, are unresponsive. Your clinical findings to detect that without an EEG are very, very subtle. You may have a little bit of twitching of the eye, some nystagmus, sort of twitching of the eye. You may have a little bit of mouth twitching, thumb twitching, but you typically don't see somebody that is shaking wildly in the bed. That typically is actually something else than in the ICU, maybe herniation or movement disorders or things like that. So underlying brain injury is important. The EEG is also important. So not everything that's sort of rhythmic or abnormal in the ICU is a seizure. I won't go into the very depths of this, and this is something for the neurologist. But when you see this in the report, it's something to take note of. So you see lateralized periodic discharges. They're on one side of the brain. They're rhythmic. You can see them bilaterally. You can see them generalized. This is something that Michel also showed an example of. You can have these very rhythmic, very brief, high-frequency discharges. If you read that in the report, that might be something that indicates that the patient is also at higher risk of getting a seizure. So it's sort of like an abnormal heart rhythm that doesn't qualify for VFib yet, but you should be concerned about. So in terms of predicting patients that have seizures, when you take the brain injuries here into account, so something that we've talked about, cardiac arrest has it more common, patients that had diagnosis of convulsive status, neoplasms, and then certain EEG findings, you can model the likelihood that somebody is going to have a seizure. This can be combined, for example, the EEG findings in a risk score. And if I think about patients that I see in the ICU that are at high risk of having seizures, I think of the underlying brain injury. So, for example, cardiac arrest, clinical seizures, brain neoplasms, maybe inflammation, even systemic inflammation has been associated with it. And then certain EEG findings that make it more likely. There's one study that actually found some factors making it less likely that you detect non-convulsive seizures. This is really, I'm not sure exactly how to interpret that. I think this is due to the fact that these patients were so sick that they even didn't make it to detection of seizures. So I think that is in the back of your mind, right? So are these seizures important? There's a lot of data in different brain injuries that have associated worse outcome with these electrographic seizures. This has been shown in TBI. There's imaging studies, for example, that show structural abnormalities that develop in patients that have electrographic seizures. There are studies in children that show that the long-term outcome is worse amongst those that have electrographic seizures. There are studies in subarachnoid hemorrhage that show that the long-term recovery and cognitive outcome of patients that have seizures are worse. And there's even studies in ischemic stroke that show worsening outcomes the more seizures you have. So it seems to be a bad thing, right? So what do we do about these seizures? Shall we just prevent them from happening at all? And so one thought is prophylaxis, right? So there's been a lot of studies that looked, or some studies that looked at using anti-seizure medications to prevent patients from having seizures in the first place. In TBI, the sort of landmark study that was done was by Temkin. This was of note in the 1980s, was using phenytoin, something that's really hard to imagine nowadays. But they found some effect on prevention of early seizures, in-hospital seizures. No effect on epilepsy long-term outcomes, but an effect on early seizures. Based on that data, for a long, long time, everybody used seizure prophylaxis in patients with traumatic brain injury that had blood in the head and were in this moderate to severe category. In a more recent look at the data, actually, it is a little bit more on shaky ground. So the recommendation of this sort of recent meta-analysis and recommendation was it may or may not be used. And probably what you should use if you use seizure prophylaxis is not phenytoin. There's a lot of data that has shown now that using phenytoin really has bad long-term effects. The recommendation is probably, at least what I do practically, is use Keppra, levetiracetam, or other medications to use as prophylaxis. Also, you should only use it for 7 days or less. So that's in TBI. How about intracerebral hemorrhage? There's actually not evidence there to support that. There are some studies that have associated seizure prophylaxis with worse outcomes. So typically overall, it's not recommended to use seizure prophylaxis. Definitely not phenytoin, and definitely not beyond 7 days on a case-by-case basis. If I have a patient that has a very large hemorrhage, is at risk of herniation, I am very concerned about the damage that a seizure would cause. Then on a case-by-case basis, I use it. But as a general whole, I don't use seizure prophylaxis. In subarachnoid hemorrhage, seizure prophylaxis, it's a little bit more complicated. There are some patients that are identified as high risk. Definitely you should consider EEG and prophylaxis only in those that are at high risk. So large hemorrhages, MCA aneurysms and hemorrhages there have been associated with higher risk of seizures. Do not use phenytoin again. So that's a common theme. So that actually made it into the guidelines there. So how do we, once we have a seizure, do we treat it or not? Most actually guidelines recommend once you diagnose a seizure, either clinically or electrographically, you should treat it. Much of the management of how we treat these seizures is extrapolated from the status epilepticus world. So in status epilepticus, and Cherylee is going to talk about that, I think. I haven't seen your slides, but I think. The initial treatment would be, a first line would be a benzodiazepine, so typically lorazepam, IV or IM midazolam or clonazepam IV, depending on where you practice, is used as the first-line treatment initially when the patient is still seizing, and then a medication. From the clinical trial that was done, levetiracetam, fosphenytoin, and valproic acid were equivalent. I think most people favor levetiracetam or valproic acid at this point. So what's the data specifically in electrographic seizures, the management? There's not a lot of data on that. So there was one study done by Hussein who wanted to compare phenytoin to lacosamide, had to stop the study early, and this showed that there was no difference between the two treatments. That didn't compare to placebo, but there was at least no difference in this early stopped trial that he could identify. That's pretty much the data that we have for just isolated seizures, how we manage it. However, in guidelines, typically it's recommended for most diseases. I just gave you an example for ICH here. It's recommended that if you detect a seizure clinically or electrographically, that you should treat it. So the question is, I think my title suggested that I should talk about should you treat or not, should you not treat. So one question is the cure worse than the disease? In the Telstar trial, which was really an elegantly conducted trial here in Europe, looking at patients with cardiac arrest, trying to see whether treating epileptiform patterns actually helped or not, the overall data actually showed that there was no difference. When you actually looked at all of the patterns that were encountered and patients were randomized to either receive aggressive or treatment or not, there was no difference. However, in the supplement you see here that this is from the supplement that if you looked at patients that have GPDs like 0.5 or to 2.5 hertz that do not qualify for seizure patterns, there was actually harm being seen with treatment, whereas in the patients that had non-GPD patterns, including seizures, then there was a slight benefit seen. But this was a post-hoc analysis, one. It was clearly not powered to show the difference because you see the small number of patients in the non-GPD patterns, also illustrating that much of what we see after cardiac arrest is actually not clear-cut seizures, right? So you can see here this was 16 versus 20 patients, so a very small cohort there, right? But it's sort of encouraging to see that there's a difference. And it may actually matter what you see there on the EEG. So there are efforts underway, and I think quite underway, and Nicolas and Michel can talk about that, but of sort of doing a study now focusing on those patients that potentially could get a benefit from that. So that's going to be data that's going to be extremely useful. So in practice, those patients at this point in time, I still treat the ones that have seizures after cardiac arrest. There's also data on patients' case series with status epilepticus that received anesthetic treatment versus not. And in those studies, these are prospective, some of them, most of them are retrospective case series, but they weren't randomized. And so in most of those series, the patients that got anesthetic treatments did worse. But that doesn't mean the anesthetic treatment did that. So unless you randomize and you do a double-blind study, you can't really say whether the patients were equal and whether that was really due to the anesthetic. So I think the jury is still out and we don't know whether it's really helpful or not. One question is there a common underlying link? And when we think about treatment, should we think about that? So seizures can cause increased brain inflammation, and brain inflammation lowers the seizure threshold. So there's the idea of going into a vicious cycle between seizures and inflammation. And that's sort of propagating worse brain injury. One question could be, should we think about targeting that brain inflammation rather than the seizure themselves? So in practical management tips, seizures are common in critical care. Most are non-convulsive, so think about that. I had one person at some point say, I don't use EEG monitoring and I don't think electrographic seizures exist because I've never seen them, but you don't see them if you don't use EEG monitoring, right? There's a vicious cycle potentially between seizures and underlying brain injury that would be important to break. Predictors of seizures are the etiology and the EEG findings. If the patient is at high risk, monitor the patient with EEG and be alert if the exam fluctuates or is out of proportion to your other diagnostic tests. Let's say you get an MRI and you don't see any injury there, but the patient clearly has focal findings that fluctuate. That should be a concern because that could be a seizure. So if concerned, get an EEG. Prophylaxis, you may use it for TBI. Some high-risk SAH patient do not use it for ICH. It's not really recommended for other brain injury etiologies. For example, brain tumors, it's not really indicated. Do not use phosphonatoin if you don't have to. At least I would say that. Treatment of seizures, consider levetiracetam. Lacosamide I use quite a bit. Valproic acid is really good medication. I try to use medications because I'm an ICU doctor, right? I like to use IV medications with PO medications. I never know with gut motility issues whether the patient really gets the medication. And I like to use medications where I can check the levels. So levetiracetam, valproic acid are good in that sense. And be alert for transitions to status epilepticus. That's it.
Any questions out there? Raise your hand.
Thanks, Jan. Excellent talk. Back to the seizure prophylaxis question. I'm always worried about recommendations because they are based on trials that have only looked at clinical seizures, but most of the seizures in this population are non-convulsive seizures, and we know that they're harmful. So what's your take on that?
Hard to say, right? I mean, you're totally right. I mean, we don't know. I mean, they're all based on clinical seizures, but unless we have data, there is now data suggesting also potential harm, right? So I think I'm telling you, if I have a concern that the patient could acutely be harmed by it, then I use seizure prophylaxis. But if not, then I don't think there's data to support it at this point.
Jan. So patient in the ICU with a hemispheric stroke has focal seizures. How far do you treat? How far do you treat?
So focal seizures are fascinating because they are actually more difficult to control often, right? So it's actually really a tough one. And I've had many patients where it's very frustrating. Often, I give it a try. I don't put them on anesthetic drips typically. What I sometimes in those patients do is I also try to get additional information to support hypotheses that it's active injury is happening, like imaging studies, for example. So if I have like a focal discharge, is it clinical or not is another question, right? So let's say the patient is twitching with their hand. That can be very debilitating. But the problem is those are actually much more difficult to manage. Sometimes actually we've had to have patients, they sometimes come out of the operating room, right? They had a surgery, for example, for a tumor resection and then have focal seizures afterwards. And then I had them go back to the OR and resect a small part of the brain that was actually causing the seizures. That's been sometimes successful for me. But it's really, and it depends how much clinically present they are. But these are patients that, are very, very difficult to treat. Often what I try initially are benzo medications and then levetiracetam. I would use as well. But they're difficult to manage. Right. I try to prevent because those patients often are not intubated, right? And so to induce then, something that depresses the mental status that the patient needs to be intubated for, knowing that often you can't actually ultimately treat it is try to prevent that.
Does the audience, anyone have experience with that? I mean, is it a problem in the ICU that rather than generalized seizures that you're encountering focal seizures and having a difficult time to address risk versus benefit and how hard to push if you're treating?
10% of patients with a stroke and an IH stroke scale above 8 have non-convulsive status epilepticus. And most of the time it's focal, and I agree with Jan, it's tough to treat. Most of these patients at my place are not in the ICU, they are in the stroke unit, which makes it even slightly more difficult to manage because, of course, we can't intubate and anything. So, we just try several non-sedating anti-seizure medications, but often these cases are refractory, I do agree.
And then sometimes also in those patients specifically, I do a benzo trial, so small doses of benzodiazepines, see whether the EEG pattern goes away and the whatever clinical deficit they have goes away.
Thank you.
So let's move on. I'd like to invite Professor Cherylee Chang from Duke University Hospital to talk to us about seizures and what are the pharmacological options.
Well, good morning. You've heard about how to recognize, diagnose, and decide when to treat. The question is what you're going to use to treat. I have no disclosures, but we're going to be talking about the immediate seizure termination, second-line therapy. You heard a little bit from Jan, and then long-term control. We've talked about that we have seizures and status epilepticus. The patients that end up in our ICU are usually the ones that have status epilepticus, so I'm focusing on that when we talk about treatment. But we have to remember that the probability that the seizure is going to stop on its own goes down after several minutes. So this is partly the definition of status epilepticus. So I tell from the practical standpoint, if the patient's seizing, you tell the nurse, run and get your benzodiazepine, whether it's lorazepam or whatever it is. By the time they get back, if the patient stops seizing, then you can go on to maybe your second line to prevent the second seizure. But otherwise, by the time they get back, if they haven't stopped, go ahead and give the medication. We know that mortality increases when the patient gets into status epilepticus for if the patient has been seizing for less than 60 minutes versus more than 60 minutes. You can see mortality is quite dramatic. So we need to try and stop this from happening. So one of the key things when you're standing at the bedside is to recognize that there's a loss of the benzodiazepine sensitivity because of internalization of the receptors. And this is showing an older study, but showing that with animals, with rats here, that it takes logarithmic doses of benzodiazepines to stop that animal from seizing if it's been seizing for 10 minutes versus a longer period of time. You're going to need a lot more for the reason we just talked about. And this is just showing a little cartoon, again, of having the GABA receptors there, that because, and initially you're going to have the NMDA receptors that are blocked by magnesium, but as there's depolarization, that magnesium is going to be pushed out, calcium is going to enter, and we know that's going to be excitotoxicity. Excitotoxicity will happen, and then the GABA receptors internalize, and the NMDA receptors come out, and we'll get back to a little bit more of why the NMDA antagonist might be helpful in this setting. But again, GABA is going to be less effective. Now, which GABAergic medication are you going to use? Again, an older study, but showing in the closed circles that this is lorazepam, and the open circles, the older diazepam. So diazepam is very lipophilic, gets into the bloodstream quickly, into the brain very quickly, but then exits very quickly. So you're going to have a little bit longer effect with lorazepam, but practically it's a little bit harder. It needs to be kept colder, so many pre-hospital areas did not have lorazepam available. So this very nice Rampart study came out looking at the difference between using lorazepam IV, and usually it's a 0.1 is what we're taught, but in this study it was 4 milligrams versus a 10 milligram IM of midazolam. And if you look at this, you can imagine that if you're just giving the medication IV, lorazepam is obviously going to work a lot faster than an IM medication. But if you think about the time that you actually had to open the box and get an IV established and to get the medication, and it's going to take longer. And you can see again that the time that it takes longer is because you're establishing the IV access. So this was done in a large group of patients and showed that there was no difference between the two medications, and even more importantly, the complications were no different as far as having endotracheal intubation, being hospitalized, ICU admission, recurrent seizures, and then hypotension, so can be used. So the takeaway from this is something very simple. We need to stop the seizures rapidly. If you have an IV access, use the IV lorazepam, and if you have no IV access, use IM. But I always think about this as the fact that you're not done, and this happens often in the emergency department, is that this is sort of a dart in the butt of the bear, because if the patient's going to go on and have another seizure, or they've been out seizing at home and they come in with another seizure, you've only temporized this patient. So you need to think about what you're going to do next. So this trial, the ESET trial, came out and said, okay, you've got your benzodiazepine and now you've failed that. You're still seizing, and they excluded a certain group of patients, trauma, and you can see this in the slide. But then they said, what are we going to use next to randomize these patients to? Done in 57 hospitals using children and adults, and randomized, and this is a 10-minute infusion. This is not where the patient's at the outside hospital, a slow infusion of a medication over an hour. In 10 minutes, you're picking, and I always think of it in this order, is that levetiracetam, 60 milligrams per kilo to a max of 4.5. Valproate is 40 milligrams per kilo to the max of 3. And then phosphenitoin, and you heard the reasons why you usually don't use this long term, but this was available for many more hospitals, is 20 milligrams per kilo to the max of 1.5. And that limit of 1.5 was because, again, with a 10-minute infusion, it can drop blood pressure. So, and if this was not effective, they went to other medication. But the key was, and Jan already showed this slide, is that they were equally effective. So we can use any of these medications immediately when our benzodiazepine fails. So when we're in the ICU or you're getting called down for a status patient, one of my first questions to ask the ED doctor, did you load a medication? Did you load? They'll tell you they gave 1 gram of levetiracetam, but they need to give 60 milligrams per kilo 40 of valproic acid or 20 of fosphenytoin. So this is a little bit small to see, but the American Epilepsy Society came up with the key things that we should be thinking about when we're managing our patients is the classic things we all know as intensivists. You're going to manage the airway. You're going to make sure that the patient heart is doing fine, check the ECG, check a blood glucose because hypoglycemia, of course, may induce seizures as well, and then get that IV access and all the laboratories that we need to do to find out why that patient's seizing. And then we've already gone through your treatment of the different benzodiazepines that you can use, and you can see that there are other rescue agents if you don't have these available. And then going on to what we just talked about based on the ESET trial. Just so going into the French guidelines, very, very similar in 2019, these came out, and you can see that they used clonazepam here rather than the lorazepam, and then midazolam as well as in there. There's some ability to give a second dose. We usually try not to do that just because it delays things, and then going into, again, the medications that we've already talked about, and then heading into general anesthesia to stopping seizures as our third line when it's refractory. So going into a very complicated slide, we're not going to go through all of these, obviously, but you can see all the different global areas that were involved in this, looking at 16 clinical practice guidelines that came out based on the Rampart and ESET trials. And you can see here that very similar, that looking at the different places that covered these particular topics. I have the evidence of grading here, but the key elements are, again, the fact that the first line is typically a benzodiazepine, whether it's lorazepam, clonazepam, or diazepam in some areas, and then again the second line, as we talked about, and then the third line. Again, what you're trying to do is get that patient into a more general anesthetic, not the focal seizures that Jan was talking about with Dr. Mirsky a minute ago. But if the patient is still seizing, you really want to use something that's going to put that patient down, and that's why they're going to be in your ICU, whether you're using an infusion of midazolam, propofol, or a barb of some type will be helpful. And then there's, of course, fourth line. So as far as long-term choices of anti-seizure medications, we're going to be thinking about, and this is often when you're maybe talking to the neurologist, they're going to be thinking about how well does it penetrate, how lipophilic or hydrophilic is it, what's the metabolism, do they have your patient have liver failure, renal failure, how it's eliminated, and other properties as well. So I'm not going to go through all of these. These are your choices, and you can see this is a nice historical timeline of bromide, which we're not using now, obviously, and then phenobarb, but then this whole list of potential medications that are now in the grab bag, depending on what your country is. But I think the most important thing is to be thinking about, if your neurologist comes in or you're picking something, to think about what is the mechanism. Again, nice pictorial, but showing that you've thought about the benzodiazepines. Those are already on board. You're thinking about the voltage-gated sodium channels. You're thinking about glutamate, your NMDA receptors, the AMPA receptors. These are all very, again, looking at where you're going to be working at. I put it in a table form of looking at, first the top are the GABAergic medications, or the barbs are into the GABAergic as well. You're getting down into the sodium channels and then AMPA channels, and then the levetiracetam, which we've heard about the synaptic vessel proteins with AMPA and NMDA, brevitiracetam, which is similar, and then perampanel, and then I'm going to mention a few things about ketamine. So I'm just going to mention a few things because we can't go through all the medications, but things that you probably are already aware about, but just knowing that we used to only have phenytoin alone. Goodness. But the problem is that even though it says it has water solubility, it has a pH of 12 and it's diluted into propylene glycol. That is going to be a problem with hypotension when you give it quickly, which is why that was a problem with the ESET trial when we had to give it over 10 minutes. So there's phosphorylated ester, if you have it available, the fosphenytoin comes off with the blood esterases very quickly, 1-to-1, and proportion, and then you can see the pH is much better. So you can give this, even we don't give it IM, but if it extravasates, it's not going to be as dangerous and damaging as phenytoin would be. That you're going to have problems with the hypotension, the things that we know about with rash, as well as problems with antiarrhythmics sometimes. And then one of the reasons, again, we don't like to use it is the drug monitoring, but a lot of side effects. And I agree with Jan that this isn't usually our first line anymore. Levetiracetam is, and I think the key element here is that it is one that has the least drug-drug interactions of all the anti-seizure medications we have available. It has primary renal excretion, so very helpful in our hepatic dysfunction patients. And we know that typically the thing that we may see, and I caution you, if you do have a TBI patient, you have them on levetiracetam for that 7-day, and they start acting very aggressive, it may be the levetiracetam. We've changed it on some patients, and they do quite well. Valproic acid, just to be aware that we see this a lot. People use it for eating disorders. Also, psychiatrists like it a lot for patients that are irritable. But it increases ammonia, so check the ammonia level if your patient comes in on valproic acid. It can cause tremors, so be aware of that. Also, if they're on it long term, you need to think about the L-carnitine may be a factor too, and checking a level there. And then I'm just going to say a few words about ketamine. It has 2 isomers. It crosses blood-brain barrier very fast. You can see you go through the literature, there's a lot of interesting articles about using now for refractory status, mostly case series or case reports, but is well tolerated, does not drop blood pressure, and you may have some elevation in ICP. But we know that patients, we always taught in medical school not to use it alone because it can cause dissociative anesthetic. But remember, most of these patients already have benzodiazepines on board. And then just nice study just showing that when you have status epilepticus, you put it either a competitive NMDA receptor antagonist or the ketamine, which is non-competitive. There's less damage to the hippocampus. Also, they've shown in studies that using midazolam alone in stopping seizures and ketamine alone in stopping seizures in the mix may be very helpful in these. Such that the reason why I show you this is that there's been some proposal, and this is mostly in children, in a study or a group in Italy that is putting ketamine in their list of the third-line medications that they would use. So I'm not going to go through this. It's just one author's potential use of how they decide to use medications. Just be aware that for focal seizures, there may be certain medications that you use for generalized seizures, that there's others, and we've talked about all this ad nauseum. And just remember, stop seizures quickly. We talked about the medications. Don't overtreat the blood pressure because they're going to have catecholamine surges, and when you give the medications, they're going to stop. Give the additional medication that we talked about, and our airway, of course, you folks know. We heard about lactic acidosis earlier this morning, but remember, it's going to be elevated when these patients are seizing. We typically don't follow those. And then, again, avoid neuromuscular blockading agents as much as you can. And if you use them, get the EEG on board so you don't miss seizures. So thank you very much.
Any questions from the audience? Okay, I have one. For low and middle income countries where, for example, levetiracetam is not available to every public hospital, how would you guide the second line therapy? Would you use phosphorylated? Sometimes it's not available too.
Yeah, I think you just have to use what's necessarily available, what you have there, so valproic acid or whatever. Again, just thinking about what the mechanism is and the side effects. But I totally recognize that, going to resource-limited places, you may be very limited in what's available to you, and even from what the guidelines are stressing. Thanks. Thank you.
Any other questions? No?
Maybe short, comment. And of course, well known by you, but there's always a risk if you treat the convulsive seizure that the patient ends up in a non-convulsive seizure. So I think low-level access to EEG monitoring would be very helpful because you don't always know whether the seizure really ended after you treated the convulsive seizure element.
Yeah, that's a very important point because sometimes you treat the seizures and then they're sleepy because of the medication. They won't wake up and you're thinking it's because of the medication, but they might have entered a non-convulsive state. So I think that is really key, and it comes into the question of resources too. So it is problematic, but often hospitals do recognize or try to, if that patient's not waking up, they want to transfer the patient where they can be monitored. But there's more limited array EEGs available now that may make it more accessible even for places that don't have neurologists, where you're able to put basically a band around the head and send the information to a center that can read it and get information back.
Thank you very much.
Our final speaker is just a Uber ride away from here. Brussels. Glad to have Nicolas Gaspard talking to us about new onset refractory status and novel options.
Well, thank you very much, and thanks to the organizer for the invitation. So these are my disclosures. One of them is relevant of a member of the North Institute, and I briefly mention it in what we're doing at the end of my talk. The question here is, why does the patient have status epilepticus? Why? That's a question that should be on our mind anytime we treat a patient with status epilepticus. Most of the things you have heard so far are about symptomatic treatment of the seizure and status epilepticus. And of course, it's super important. You have to stop the seizure as soon as possible. But at the same time, if you don't know the etiology, if you don't treat the etiology, especially in cases with refractory status epilepticus, you might not manage to terminate status epilepticus, right? The good news is that most of the time the etiology is obvious, right? 80% of the time it's an acute brain injury that you know from CAT scan, or the patient has a history of epilepsy, forgot to take his medication, or the neurologist had the bad idea of changing the medications a few days before. Might be infection you get from a lumbar puncture, might be acute metabolic disorder that you find in the lab, right? So that's 80% of the cases. But that leaves us with 20% of cases where the etiology is not as obvious. And that includes situations that might require specific treatment, like autoimmune encephalitis or some atypical rare CNS infections, some genetic disorders, right? That will require more investigations and specific treatments. And then sometimes whatever we do, despite very extensive investigations, we don't find the etiology. So to put it in kind of a flow chart, you start with your initial workup, and for instance, the American Epilepsy Society 2016 guidelines are excellent in briefly describing what you should do in every patient that comes in with status epilepticus. And sometimes, well, most of the time with this initial workup, again, clinical history, neuro exam, basic imaging, maybe ULP if the patient is febrile, we'll get the etiology, and you may start an etiology-specific treatment, right? Acyclovir for HSV1 encephalitis, or something like that, right? If it's a stroke, you might get thrombectomy and so on. But sometimes you don't get the etiology from this early workup, and it's a situation that's kind of troublesome, right? So if it's refractory status epilepticus, these situations where the etiology is not easily identified within the first 24, 48 hours of onset, it's called new-onset refractory status epilepticus. That's a consensus definition that was put together by quotes experts, unquotes, that are at least interested in the field, and wanted to come up with an operational definition that could be used for research, but also to maybe help the clinical management of those patients. So what's NORS? Well, NORS is a clinical presentation, right? It's not a disease. It's not a disease per se. It's just a clinical presentation. Someone with acute onset of refractory status epilepticus and no history of active epilepsy, no relevant neurological history, and no evidence of an acute etiology identified within the first 24, 48 hours, which is usually the time you need to get your HSV1 PCR back from the lab. And then there is this subcategory of NORS, which is called FIRES, febrile infection-related epilepsy syndrome. It's actually a subtype of NORS that's preceded by a febrile episode, a couple days up to a couple weeks before the onset of seizure, right? in those situations where you have new-onset refractory status epilepticus, then you will do an additional extensive workup, trying to look for these additional etiologies like autoimmune encephalitis, atypical sinus infection, maybe some genetic disorders. And sometimes you will find the etiology. And then again, that may lead to etiology-specific treatment. If it's antibody-mediated encephalitis, well, you'll start rituximab, for instance. If it's an atypical CNS infection, maybe there is some specific antibiotic that you need to give to your patient, in addition, again, to treating symptomatically the seizures. Sometimes, and these are the very, very, very frustrating cases, despite this very extensive workup, you don't find an etiology, and that is what we have defined as cryptogenic new-onset refractory status epilepticus, or north of a known etiology, and that also applies to fires. You can have cryptogenic fires or fires of a known etiology, cases where, despite extensive investigation, you don't find an etiology. And it's an area in which there's been quite a lot of recent developments in terms of understanding why this patient might have refractory status epilepticus, and I'll talk about them in a moment. We've put together some Delphi-based recommendations on how to approach a patient with NORS or fires. There are two versions of the recommendations. I don't recommend this one. It's 85 pages plus supplements, so it's quite a bit. Unless you have a problem with insomnia, that's an excellent cure for your insomnia. There is a short version of it that comes with flowcharts and tables. I'm not going to go into the details. I don't have time, but you can refer to them. That kind of suggest it's not. It's not evidence-based. It's kind of eminence-based, not evidence-based. But this is how this group of people would approach the problem with suggestion of a hierarchical, a tight approach to workup and treatment. But let's get back to etiologies of NORS. So you have a patient, you rule out the acute, the obvious etiologies, right? What do you end up with? In approximately 30% of cases, you will find an etiology in those patients, right? 50% of them will have autoimmune antibody-mediated encephalitis. 10% of them, again, uncommon CNS infection, and 5% or so with something else. And among something else, there's one thing I would like you to remember: mitochondrial disorders, right? The patient with mitochondrial disorders might show up in your ICU at almost any age with the first ever episode of status epilepticus. It's rare, but it's treatable, and there are at least things that you should not do in those patients. So looking for those patients with mitochondrial disorder, especially POLG1 related syndromes, might be very, very helpful and possibly save the patient. The cryptogenic ones, 70% of them, although it looks like a bucket of anything else in which we don't find an etiology, right? It might actually not be the case, because if you look at the clinical history of those patients, the natural course of their disease, they all look very similar. Many of them, if not most of them, will start with some sort of mild infection, right? Mild viral infection could be a upper respiratory tract, could be a GI tract infection. They might get fever, but not always. Again, if they have fever, it's called fires. It's much more frequent in children than in adults, probably because as adults, when we're sick, we never take our temperature. Or as soon as a child is sick, the parents will take the temperature. But adults often have a mild side of infection a couple of days or a couple of weeks before the onset of seizure. And seizures kick in. And they're initially, once in a while, focal seizure without impairment of awareness, and then with impaired awareness, and then they evolve into bilateral tonic-clonic seizures, and then boom, it goes into status epilepticus that become refractory, and very often super refractory status epilepticus. And this acute phase can last for a few days to a few months. I think the world record is 168 days. Seizing in the ICU with excellent outcome. So that's another thing to remember. These patients can seize for a very, very long time and yet have a very good outcome. And then at some point, after a few weeks or months, the seizures stop, whether it is because we do something about them or it's just a natural course of the disease. At the moment, we still don't really know. The outcome is variable. Mortality goes from 10 to 30%. It's higher than adults. So it's still a very severe condition. The vast majority of patients have drug-resistant epilepsy, so they will keep on having seizure, not status epilepticus most of the time, but they will keep on having seizure throughout their life. And approximately half of them have long-term cognitive dysfunction, behavioral problem, and functional disability. So it's quite a severe situation. These are data that we recently published on the long-term outcome. So active epilepsy in almost all the patients, typically drug resistance, usually multifocal, so tough to treat chronic epilepsy. Many of them had, a third of them were able to go back to work or prior education. Sorry, the pointer doesn't seem to work anymore. Most of them had cognitive issue or mental health issues. If you do imaging in those patients, the acute MRI is usually normal. If you repeat the MRI 7 to 14 days afterwards, you might find these signs. Oops, the pointer works again. That's great. If you look at the claustrum, which is this band of gray matter. Sorry, the pointer doesn't want to work anymore. So if you look at the claustrum, which is below the insula, these are the white stripes that you see on both sides of the brain. The left panel is the acute MRI. The right panel is the follow-up MRI. They go away, right? These are the white spots that you see, the white bands that go away. If you see that in your patient, it's very likely that it's cryptogenic noise or fires. This is very, very specific of the condition. Why do these patients have seizure and status epilepticus? And that's where I think we've made most progresses in the recent years, mostly thanks to the work of the Yale group, the Pitié-Salpêtrière group, and the Mayo Clinic group. What we believe at the moment, and it's based on looking at cytokines and chemokines in the CSF, in the serum, doing some genetic testing in those patients, thanks to an ongoing registry in Biobank that we are running. What we found in this patient is that they have super high levels of a variety of cytokines in the serum and, importantly, in the CSF. IL-8, IL-10, IL-4, MIP-1 alpha, also interleukin-1b. Jan mentioned the role of inflammation in the generation of seizures in the ICU. It's very likely that these patients have seizure because of massive inflammation and the presence of cytokines, that if you put them on an hippocampal slice in a petri dish, you will induce seizure in this hippocampal slice, right? So this initial hyperinflammatory response, probably to this minor viral illness that they had a few days ago, will trigger the seizure in status epilepticus that will keep on increasing the amount of inflammation, and that's kind of a vicious circle where more seizure leads to more inflammation, that leads to more seizure, to more inflammation, and so on. So this data about inflammation led some group to think that maybe targeting the inflammation was the key to treat these patients. So this is where the new options arrive at. And there are actually 4 different approaches that have been tried. Admittedly, in small case series, it's only maybe 100, 200 patients treated so far with one of these drugs. In children, what's very, very popular is the ketogenic diet. Pediatric neurologists are really huge fans of the ketogenic diets, and they're very good at it. I'm terrible at it. I've never managed to put a patient in ketosis in the ICU for many reasons, but mostly because I'm not used to it. But in children, it seems to work quite well. One of the reasons is that the ketogenic diet has anti-inflammatory effects. So ketogenic diet is an option. In pediatric neurologists have also tried the anakinra, which is an antagonist of the interleukin-1 beta pathway, kind of the key player in this innate immunity inflammation that's triggered in those patients. So it works. 73% of response in these super refractory cases, so that's quite impressive. If you started earlier, it works better, but there are lots of side effects, and 50% of serious side effects, especially infections, right? Remember, if you target interleukin-1 beta, you actually knock down your innate immunity system, which is what you absolutely need to resist against all the germs that are in the ICU. In adults, what's more popular is tocilizumab. It's an anti-interleukin-6. You all know about it from the COVID pandemic, of course. It seems to work as well. So interleukin-6 is just downstream of interleukin-1 beta. So you're just acting one level below. It seems to work quite well, 70% of response, quite impressive as well. But again, serious side effects in a lot of cases, especially, again, infections. And then the recent one, which is probably that doesn't sound as exciting, but actually it seems to be working quite well and with much, much fewer side effects, is intrathecal dexamethasone. Right? The inflammation in those patients is in the brain. Right? So let's target the inflammation in the brain. And how do we do that? Well, we put steroids in the CSF. It sounds barbaric to me, But actually, we're talking with a colleague of mine who is a very, very old MS specialist, multiple sclerosis specialist. He told me, well, you do that all the time before for relapses of MS. It's absolutely fine. And if you think of our hematologic oncology colleague, they do that all the time with very bad chemotherapies, right? So intrathecal dexamethasone is actually quite safe. We've done it a couple of times. And others have done it as well. It seems to work quite well with very, very few side effects. And all of this has been summarized in a nice review by Aurélie Hanin that was published last year in Epilepsia. It's a systematic review of all the published cases and case series with recommended doses and so on. So to get back to this chart and wrap it up, I think when you think about it, it's always about finding the etiologies, right? Either the obvious one and initially and very quickly you can get your patient on the drugs that you need. If the etiology is not obvious, then look for autoimmune encephalitis, look for atypical CNS function, think about mitochondrial and other genetic disorders, because that might lead to specific treatment as well. And if despite all these extensive investigations you can't find the etiology, just don't stop there. If the patient falls in this category of cryptogenic NORS or cryptogenic fires, then there might be targeted immune therapies, tocilizumab, anakinra, and I think probably most promisingly, the intrathecal dexamethasone might be what you need to give to your patient to stop the seizure. With that, I'm done. Just like to mention the North Institute. That's a group of people has been together by a family who lost a son to North some years ago, and they did a great job at putting together lots of people around the table, get some funding so we could start this prospective registry in biobank. And most of the original data I showed you today was done thanks to all the effort of this family that really pushed us to do the registry, the biobank, and asked questions. With that, I thank you very much, and I guess we have a few minutes for questions. Thank you.
Open for questions? Anyone? Yes, sir.
I always have to remember. It's in the table. I never remember by heart. It's in the table. Epilepsia 2024, Hanin, Hanin.
Yes, sir. Michel?
Thanks, Nicolas, for a great talk. So dexamethasone intrathecally, but you can also give it intravenously, right? Methylprednisolone.
Oh, yes, you could. So methylprednisolone.
Why would you do it with a lumbar puncture, right?
I guess for two reasons. First, methylprednisolone doesn't really cross the blood-brain barrier really well. But you could use dexamethasone, right, systematically, because that goes through. Yes. But I guess you want to avoid the... first, I think you want to reach very high concentration in the CSF, which you may not reach with systemic administration. And also you want to avoid the side effects, right? You want to avoid the systemic exposure to steroids.
Although in acute brain injury with infection or inflammation, the blood-brain barrier is much more leaky, right? So I would assume that actually quite a bit of the steroid does get into the systemic circulation. And I mean, they had a very small case here. It had no side effects. I would caution.
Sure, yeah. I said fewer side effects.
No, in the
in the small case series, yes.
And I think, I mean, there's quite a bit of data. I mean, Mark, you might know this better, but for spinal anesthesia to prolong the effect of the spinal anesthetic, sometimes there are some case series using dexamethasone infused into the spinal sort of space. But I don't know, because for this you would have to use it for a long time, right? I mean, for fires or so, it would be for a long. I mean, you wouldn't just do one dose, right? Or
no. You usually you see the response. I mean, again, this is based on a few case reports and exchanging experience with others. Usually, when it works, you see the effect right after the first dose, and it lasts for a few days. Then you have to come back and we've done. Usually, you do between 2 to 5, 6 administrations, so it's not that many actually. And empirically, most of these patients have received IV methylprednisolone anyway, right? And it didn't work. So there is something that suggests that intrathecal administration works better. Of course, it's a selection bias, because if you go to intrathecal dexamethasone, it means they've already failed intravenous methylprednisolone, which doesn't mean that actually intravenous methylprednisolone might work. And I've seen at least one case where giving methylprednisolone IV worked splendidly, but we took the case very early on in the after onset. Yeah.
So I have a question, and I invite all three panelists to chime in here if they like. So you have a patient with like NORS or fires in an ICU that you may have. So the practical consequences, you have to treat them daily in the ICU with status. So what is your recommendation of what is your medicines that you use? How do you use them in terms of what sort of EEG pattern do you want to evaluate every day? And when do you know you're going to be finished as you're loading the patients up with these other medications?
So one of the things I'll start with your last question, like what depth. I didn't go into that slide of the guidelines of all the different places, but there was a variability in whether patients, they're looking for burst suppression, which used to be our old standard, to seizure suppression, which is, I think, what most people are adopting now. And so I think it varies depending on the center. So I'd be curious also what others, but I think it's using the anesthetic doses of barbs, typically for us, or midazolam at very high doses, milligrams per kilo, basically, and then adding agents.
So the way that I think about management of status, and let's say that this patient is in status, I think of it always as two axes, right? And so one is treatment of the seizures, and then treatment of the underlying problem, if that's possible, right? And then prevention sort of the long-term effects. So basically, the status, no matter what the etiology is, pretty much I try to treat similarly with a benzo, and then try to sort of, if the patient continues to seize, then I would go to potentially after levetiracetam or valproic acid, depending on the patient, going to anesthetic drips. But then in the background, when I think about the underlying problem, exactly sort of illustrating, basing on what Nicolas is saying, so if it's an immune-mediated problem, then I do think about, is plasmapheresis an option? Is IVIG an option? And I continue day by day. The status management is basically I try to suppress the seizures for 24 hours. If there's no seizures, then I start to wean the medication off. If it's, I try to wean them slowly over a day or so. But that's basically independent of the underlying management of the problem, right? So to the plasmapheresis or the IVIG or the intrathecal steroids, I have not used, but it's great when you learn something. You give a talk somewhere and you learn something, so this is great. So I might use that. But I think of independent of the management of the seizures. Let's do that in parallel. And then if the patient, while I'm treating the patient with plasmapheresis and is going back into seizures, I go back on the seizure status algorithm. If, for example, I've completed the underlying problem treatment, plasmapheresis, and the patient had not been seizing, but then seizures recur, I may think about a second round of plasmapheresis or so.
Nicolas, anything?
Yeah, but back to your question, which I guess was about the intensity of treatment and when do you quit. I think I always try to balance, efficacy and side effects, right? And this balance, in my mind, shifts a little bit with time. So initially in status epilepticus, I'm very, very aggressive the first few days. But then when you get into these cases, which can be very, very long, you start to tilt your balance slightly differently. And I always go for seizure suppression and try to get rid of all the seizures, at least during the first 24, 48 hours. But at some point, if that doesn't work, and I'm, starting to pile up the anti-seizure medication, I may back off a little bit from this seizure suppression and maybe tolerate a few seizures a day just to minimize the exposure to potential toxic drugs. When do I quit? In those patients with cryptogenic NORS and fires, as long as the MRI doesn't show any catastrophic things, I will continue. There are many published cases with an excellent outcome. I mean, one of our patients spent 90 days in the ICU and was back to college a few months later, right? So there are many cases, mostly young people with a normal MRI, and I'm not counting progressive atrophy is abnormal, because you see that in many patients in the ICU, regardless of the underlying etiology. So as long as the MRI doesn't look too bad, I will keep on fighting for those patients.
I think that's a valuable point, because I think most of us who do treat patients like this, if they are, by imaging standard, they seem to be holding their own. We continue being very aggressive and have all seen very good results with even weeks, even months of status. So, thank you all.
Thank you.
Well, thank you.
Thank you.
It was great. It was fun.